that Mark was going around to all these places giving this interesting talk about social media and public health stuff, and he hasn't actually given a talk about it here in CLSP, at least not recently. So I asked him to come and talk about it here. So,
okay,
Mark.
That's a great made-up story that explains this talk. So the reason I decided to talk about this and not something else is that many of you have heard about the something else I do because I tend to talk about it a lot, or my students will talk about it. So I decided to talk about things that you guys probably haven't heard about because, you haven't. I don't know why. You just haven't, unless you were following me around when I was giving this talk. So that's caveat number one. So there's a little bit different in terms of we don't normally talk about this stuff here. The other thing is this talk isn't for a CS or NLP crowd. This was a talk that I wrote for a public health department or school or what have you. So it's a little bit light on technical details, but the point of it is to kind of show the diversity of things we can do and some examples of things we can do. So I still think it will be interesting for people here. I think you guys will get the public health goals. If you don't, you can ask. And if you want to ask more details about some of the technical stuff, that's fine, and I'll try and add it as I go. Okay, great. Let's get started. So opportunities in social media data for public health. The word social media on this slide is going to be taken very, very broadly to include lots of things. And then later on I'll say social media to just talk about one specific type of data. All right, so let's talk about public health. So public health, for those of you who don't know, is the prevention of disease, prolonging life, and promotion of health. And you might say, that sounds a lot like what my physician does anyway, or at least I hope they're doing that when I go to see them. So what exactly is public health? And basically the way to think about it is individual health is one doctor, one patient. Public health is 1 million patients. Somewhere between 1 and 1 million we draw the line between individual and public health. And I don't know where that line is drawn, so you can figure it out. And there's room for debate about that. So that's public health. So what are the sorts of things that public health does? So disease surveillance, which means how many people roughly are sick or what diseases do people have. Self-medicating behavior, so what medications are people taking by themselves, not seeing a physician. Vaccinations, you all should have gotten the flu shot this year. It's free, it's over there, Clipper room. Education, so educating people about health use, tobacco use, which we don't support, becomes the red X. And drug use, and I mean here both prescription drugs or illicit drugs, a whole host of things. Okay. So if you ever take a class on public health, which we actually do offer in the CS department here, it's a short course in the spring, you'll learn that there's a 9 or 10 step cycle to the public health ecosystem or whatever. If you walk around the halls of Bloomberg, you'll actually see posters. So I've simplified it to a 2-step process, okay? So the 2 steps involve a population that we want to make healthy or keep healthy. And the second part is doctors or people who work with doctors, like public health officials, don't necessarily have to have MDs. Okay, that's the second group. So the 2 steps of the cycle are surveillance, where the doctors want to learn something about the population. And the second step is intervention, where the doctors, based on what they've learned about the population, do something to make the population healthier. Okay? This is a cycle because we're not done. The doctors then see, well, did our policy work? Did it make people healthier? If so, great. If not, what can we do to refine it? So let me just give you a very simple example. Seatbelts. So seatbelts are one of the greatest public health inventions in the past 50, 60 years. Seatbelts have saved numerous lives. Everyone here hopefully uses a seatbelt, and that's because there are public health officials that for decades have been pushing that agenda, right? So what we did was we saw lots of people were dying in car accidents. We came up with seatbelts. That was the surveillance part. We came up with seatbelts that improved the health of the population. And then we did things like said, okay, well, not everyone's wearing them, so let's pass state laws, or let's come up with airbags. And there's been pushes over the years to keep innovating on car safety, right? And cars today are incredibly safe compared to where they were many years ago. Deaths and injuries from car accidents have dropped by staggering amounts. Okay. All right, so public health is, as I said, improving the health and quality of life in the population. So where I come in is this requires data. We need to know something about the population if we're going to do surveillance on the population. Otherwise, we're just guessing. Okay, so the normal way people get data about the population is they either do surveys or clinical visits. So when you go to the doctor talks to you. Someone might call the doctor and say, how many of your patients have asthma, or how many patients have this disease, or are patients taking these drugs, right? That's one way we get information. The other way is surveys. Right? I don't know if anyone here, you can raise your hand if you've participated in some kind of health survey where someone called you. I actually participated in one a couple years ago. But basically, people call you up and ask you questions about health, and you try and give them honest feedback. There are many, many, many surveys like this. The largest one, or one of the largest ones, is run by the CDC that calls about 350,000 people on a yearly basis in the U.S. It's actually run by the states on behalf of the CDC, but whatever. So that's where we normally get data from. The problem is this is really limited the sort of research that we can do because there are many sorts of things that we cannot get from from looking at clinical visits or surveys, right? So outcomes or incomes, social media. And this slide is a little bit old. It was made like last week, so there's a couple new companies that probably aren't on here that should be, and some that have been acquired by Facebook, no doubt. And social media is a really interesting data source for a number of things. So people look at it for politics, sports, entertainment, people talk about work, people talk about what they eat for breakfast. But what we care about here is that people talk about health, right? And so what we want to know is how social media can be part of this public health conversation. The basic idea is of why this is even relevant at all is that social media reflects everyone's ongoing life, right? So what do you type, or what do you tweet, what do you put on Facebook, right? You kind of talk about what's going on in general in your life. And for most people, health is an important part of what's going on in their life. It might not be the major focus of what they talk about, but they often throw out a lot of comments that are very informative about their health, right? So if we mine social media data, we can learn something about health, right? And so the idea here is that there's both an opportunity for surveillance to learn information about a population, but there's also room for intervention, right? So let me give you some examples of what I mean, right? So surveillance, what we want to do is take existing things that we survey and do them better, faster, cheaper, right? So how can social media allow us to do a better job of things that we're already doing? But the really exciting part are new opportunities, things that we cannot do with existing data resources that we now can do with social media data, and I'll give examples of both. What I won't talk about, but it's very important, is intervention, where people look at how we can use social media to actually implement policies. And there's a lot of exciting work going on in the field of psychology, disease surveillance, vaccinations, food poisoning, all that are based around this idea that social media is a tool for communicating with the population about various public health aspects. So I'll just be talking about surveillance, which is where the work we've done is focused on. Okay, so that was a very broad use of social media, right? If you looked at the images I put up, it was lots of different sources of data, right? But I want to talk about three specific categories of data. The first one is search logs. The second one is social media, where now I actually mean things like Twitter, Facebook, Google+. Has anyone heard of Google+? I don't know. Okay. It's a relatively new product. And web forums. So search logs are going to be really good for coarse trends, which is sometimes all we really need, so looking at general trends in the population. Social media is really good for shallow content analysis, and we talk a lot about that here in the context of NLP. And web forums are going to be really good for doing deep dives on very specific questions. And we'll give examples. There's a 3-part talk. We haven't started it yet, but the 3 parts are going to be each one of these. All right, any questions before I go on to search logs?
Yeah.
Yes?
So,
Say your name before you...
So my name is Miles.
Hi, Miles.
So why do you think that... So when you say search logs are good for course,
Oh, okay.
do you mean the published stuff?
Yeah, the stuff I get. Michael's done work where he has search logs that he keeps locked up in his apartment that he can't share with anyone, that you can actually do some really fantastic, much deeper sorts of stuff, even deeper than the sorts of things we can do on Twitter, because you have these sessions and you can look at behavior over time, and it's really fantastic stuff. So I just mean the sort of stuff that normal mortals can do with the data available to us. And if you so happen to work for a company that runs a major search engine, like A9, anyone know A9? Okay, 2 people. Wow, okay. It's Amazon's search engine. They have one. Then you can do some much cooler stuff. Okay. Now everyone's Googling A9. Okay. 9 not spelled out, just the numeral 9. Okay. Search logs. So let me tell you an example. We actually have a number of projects going on using search logs. One question that we wanted to answer. So the question is very simple. What is the impact of the economy on the public health of the population, right? On the overall health of the population. So we think that economic trends are going to have an impact on the health of the population. Specifically, during a recession, right? This might lead to people being more stressed and more physical pain. There might be a lot of negative health outcomes just by there being a recession, right? And specifically, we happen to have had a fairly major recession in the United States recently that we can look at to try and answer some of these questions. Of course, getting data for this is incredibly hard. We need a large population to try and answer this. We have a long time span, so we want to look at before and after before and during the recession. That's a long period of time, perhaps. And we don't really know what we're looking for. So there's many things that we want to investigate in terms of health impact, and it's hard to come up with a survey that asks all these things. So instead, we're going to use Google Trends, which is the mortal solution to search queries. So for those of you who are familiar with Google Trends or not, it's a service where basically you type in queries, and Google will give you plots over time about how many people search this query. Assuming the query is relatively popular, you can all Google your names to see if there's a trend for your name. Probably not. And they also give you information about location and things like that. Right? So it actually is a very cool service to try and visualize data. Don't go run off and use it because it's actually really hard to get data and to merge it together and to normalize things correctly. But if you're interested in this, you can talk to me. I'll tell you how we do it. So what we did is we found 343 queries from Google Trends that were health-related. We looked at increases in these trends during the Great Recession, and we selected the 100 that showed the greatest increase. And we identified the Great Recession as being roughly December 2008 to the end of 2011, which is where our data stops. And we want to know how much search trends increased for certain types of queries during this time. Right? So here are the biggest increases we saw. These are mostly group terms. So headache-related queries, like headache symptoms, headache diagnosis, just the word headache, these go up by about 41%. Chest pains go up 35%. Hernia, that was the best hernia picture I could find that I could show. That's 37%. And just to give you an example of one query, stomach ulcer symptoms as a query has this massive increase. Any one query isn't really informative, but it's interesting to see that one going up so much. This is what it actually looks like. So here's our plot for 2006 to the end of 2011. Each one of these little lines is one query. And that's the pattern of the query over time. And so you can see that there are many things influencing queries over time. They go up and down. And if we look at any individual query, it looks kind of random. But the bold line here is the mean of all the queries. And you can see that this is actually fairly stable for the first part. And then right here is where the Great Recession starts. You can see a notable increase. Right? So I'll just give you one example. This is the query headache symptoms. So you can see we fit, this is a linear fit to the query patterns before the Great Recession started. So it says it's going down, but what I basically interpret that as is it's relatively flat because you don't really see a big increase or decrease. But you can see that very clearly what's going on in the Great Recession, which is the shaded region, is a major increase, right? The number of people who are searching about headache symptoms went up quite a bit. Right? And so we can see that actually there's a fairly big impact on health as a result of the recession, where people started searching much more for things about physical pain, stress, things like that during the recession. So this is a really interesting example of something that is very, very hard question to answer, but we were able to answer it by looking at query data. All right. So that's what I want to say about query data. We have like 4 other projects that we're in the middle of doing similar things for all different sorts of analyses. But it's very exciting stuff. Okay, yes?
So from the title of the paper, I would think that headache wasn't the only thing you looked at? Did you look at?
No, we looked at, there's like, we looked at a couple hundred things. So they're like headache, there's like headache, hernia, physical pain of all different kinds. And the thing is with these
those are all things that got elevated by at the time.
Yeah, so aggregated all together, we see the increase. Each individual, so, oh right, I have to step for this. Right, so these are all individual things that increase.
Yeah, okay.
right? And there's a lot more in the paper. And we also have statistics about like how many extra, like we have projections for how many extra queries there were because of the recession for these things. Like people get headaches no matter what, but how many extra headaches there were, that sort of thing. Yes?
Did also something decrease?
So we looked at health. I don't remember if anything significantly decreased because of health. There are, I mean, you can apply the same analysis to other things. So, for example, divorce decreases during recession. Does anyone know why?
Decreases?
Decreases.
Because the lawyers are expensive?
Because lawyers are very expensive, people don't have money. Which means that when the economy recovers, there's a spike in divorce.
All that pent-up demand.
Yeah, I mean, it's serious. So we were just looking at health, and nothing we saw specifically, because we were looking for, these kind of like physical pain and that sort of stuff. You can imagine there might be sorts of questions health-related that do decrease, like, health insurance might decrease because less people are looking for it. I'm not really sure.
Because I'm thinking if nothing decreased, it just might be perhaps, people have more time to see the computer.
Right. So we do normalize by total query volumes. So if it was the case that during the recession everyone had more time and so they just searched about their health more but nothing else, then you could imagine this effect. But if it's people sitting and searching more overall, then we wouldn't be fooled by that. Okay. And of course, I mean, I should say, whenever you're talking about medical results, right, this is not a conclusive proof of anything. This is just one attempt at answering a question that people have had that we've never been able to really answer, right? So the next step, I think, would be taking these results and building them into do like survey-style questionnaires. Yeah.
How do you normalize for other sort of global health events? Like
How do you normalize for what?
other global health events, like H1N1?
Right. So we didn't look at flu as part of that. Oh, you mean how, if we're interested in flu, how do we normalize?
Right. So I mean, H1N1 was 2009.
8.
So
2009, yeah.
So then if you have the flu, you may have a headache, you may have vomiting. So how do you deal with that?
So that effect would not be, so like H1N1, for example, that wouldn't be a sustained effect through the Great Recession because H1N1 kind of died off by the end of October, and also it had a huge peak in the middle of basically like two notable peaks. One was the summer when everyone wanted to know what was going on, and then the other one was in January 2010 when it actually was kind of at the height. But it drops off really substantially after that. So it might be that people were searching, it could be that people increased headaches searches for that. I don't really think they would. I mean, if I had the flu, headache symptoms would not be what I searched for. It would be more flu-related stuff. But that wouldn't explain the trend over the whole recession. Okay, social media. Everyone knows what Twitter is. Great. If you don't, I'm sorry. You just see me after. Why do we use Twitter? A couple reasons. We have it. We have a lot of it. And people write things in Twitter that are actually really indicative of health. So here's some examples. Nothing like waiting in line to buy cigarettes behind a guy in a business suit buying gasoline with $10 in dimes. So while that's amusing, what we actually learn from that is this person's probably a smoker, otherwise why are they buying cigarettes? Right? So it's not conclusive that they're smoking, but it's an indication of a smoker. Right? And so those are the sorts of things that people say incidentally on Twitter that we want to try and mine to do interesting things. So we've done a lot of interesting things with this. We've looked at medication use. We've looked at patient safety, like medical error. That's a big thing here at Hopkins and the Armstrong Institute. We're doing work now in mental health, depression, post-traumatic stress disorder, a whole bunch of things. What I want to talk about specifically today in detail is our work on disease surveillance, which is really kind of one of the first things we've done, and we haven't stopped yet. Soon. We'll stop soon, but not yet. Okay, so disease surveillance. So if everyone remembers, last year was a pretty notable flu year. Even if you didn't know that, the fact that there's a New York Times article from January 2013 on the flu means it was a notable flu year. That's not something we normally see articles about. And the reason it was notable is because it reached what we would say is epidemic levels in the United States. Right? The rate of flu infection was much, much higher than we normally see. Not once in 100 years, but like once in 10 years sort of high. I don't know exactly how the statistic of when the last time it was that bad. Why do we care about this? So most people in this room, hopefully, who have had the flu get the flu, they're out for a couple days, and then they come back and their life moves on. But for a lot of people, that's not how the flu goes. The flu is actually a very serious illness, and there are many, many people who die or are hospitalized every year in the United States from the flu. Right? I really should look up the statistic about what percentage of annual deaths are from the flu. Michael, if you know, you can shout out. But all right. So it's actually a really big impact on public health. And so as a result, the CDC spends a lot of time, effort, and money on influenza. It's one of their big areas where they focus attention. So the way they do surveillance for the flu, right, where they want to know basically how many people right now have the flu, is they have what they call their ILM network, different names for it. So they have 2,700 outpatient centers throughout, or also some hospitals throughout the United States, and these centers report weekly to the CDC how many people showed up that had influenza-like illness. And what that means is you went to see the doctor, and you said, gosh, I have a fever, and I have the chills, and I've been home for 2 days, and the doctor says, really, that sounds like the flu, here's some medicine, go home. That gets reported as ILI, okay? Critically, that doesn't mean that you actually have the flu. It just means that you're someone who looks like they have the flu. There's a separate metric they use for confirmed flu cases, but that's less interesting and less useful for most people than the ILI number. Right? So the main problems with this is it takes a while for them to compile it. It's about 2 weeks for them to collect and publish the data. Even once they do that, as we've discovered, they update it frequently. So even though they publish a number the next week, they might make minor or even major revisions to it. So it really takes a while to collect this data. And also there's varying levels of geographic granularity. So the CDC really focuses on regions. There's 10 regions in the United States. They have some state level data, but they really don't have things unlike Baltimore, right? But the problem is if you're a hospital in Baltimore, you kind of care about what's going on in Baltimore more than you care about what's going on in the United States. All right, so we're going to build a Twitter surveillance system for influenza, and it's going to have 3 components that we think are new and interesting. One is we're going to show that we can accurately track ground truth infection, and we're going to have methods based on NLP, so good for us, that are improvements over what other people have been doing. We're going to show that we can do this not just at the national level, which is what everyone's shown, but at the local level, so cities. And we want to show that we can not only do this historically, like download old CDC data and show that we can do well, but we can actually build a system and run it on real data coming in and do well. All right, so let me go through each of these points. So you guys are familiar with the complexities of natural language processing. Not everyone is, which is why I have this slide, but I'll show you the examples because they're cute. So the most common thing people do is they look for the word flu, which would get them these tweets. The Ray Lewis flu, does anyone know what that is? I went somewhere where no one had heard of Ray Lewis. Does anyone know who Ray Lewis is? In Baltimore? Okay, good. Just making sure. It's amazing to me. This is what happens when you leave Baltimore. So Ray Lewis was the linebacker who retired last year for the Baltimore Ravens, and apparently his attack of the offensive players was so fearsome that offensive players in the opposing teams would feel ill the week before playing him. That's called the Ray Lewis flu. Not contagious. Mom, I can't go to school tomorrow. I have the swag flu. Does anyone know what swag flu is? Show of hands. No? One? Do you want to define it, or should I?
Well, swagger is sort of like the way you walk and the way you present yourself to the world. If you got a lot of swagger, you're pretty suave.
Yeah.
So if you got the swag flu, I'd imagine that you're so fly you have to stay home.
So, very good. I like this. So I'll read the Urban Dictionary definition, which I love, so I'll read it anyway. Swag flu is a contagious virus that spreads game, confidence, and swagger among the populations of individuals. So very good. That was good. As deadly as that might be, we don't actually care about tracking it. Or at least no one at the CDC has approached me about tracking it, so we haven't looked at it. And you can see other things like this in the data. So keywords are not enough. This is not just a cute problem, it's a serious problem. Here is the summer of 2009. And the curve I'm showing you is what our system thinks the flu rate is, and I'll explain later where that curve comes from. And what is odd here is that there is a big spike in the flu in the middle of summer, and that's not common.
So when you say our system, do you mean one that just looks for the word flu?
It's a little bit more advanced than that, but I'll explain later what it is. But it's basically just doing more naive stuff.
Okay, so this is the baseline system.
This is the baseline system. Well, this is one of the baseline systems. It's still a statistical system, but it's not, you'll see in a minute. So we see this big spike here. Is that an infection spike or not? So actually what happened on that day in 2009 was the World Health Organization declared that swine flu would be a pandemic. So as much as that raised awareness about the flu, I don't think this press release made anyone sick. And so the fact that the system confuses these things is a bad problem. Right? It's not just this system that would do that. Last year there were some very interesting articles published in Science News. Science News? Okay. Basically the title was like, Google flu trends doesn't work. It was a little bit more diplomatic than that. And the point of the article was that because there was so much media interest in the flu that year, there were all these articles, people were searching for the flu even though they didn't have it, and it misled Google flu trends to way overestimate the flu rate. So it's not just a problem on Twitter, it's a problem with Google data as well.
So that's going to be difficult for you even if you leave out articles like this, right? So you said this article didn't make anybody sick, but it may make people think they're sick.
Right.
And that might show up even with more subtle measures.
Right. So to convince Jason, I will show you this plot again at the very end of this section and show you that we did better.
Cool.
Okay.
Well,
Anticipated. Yes.
do flu symptoms also peak here as well as the word flu?
This is just tweets that our baseline system identified as being about the flu, which is what people typically use to do flu tracking.
But if you ignore words like flu and H1N1, which are...
Yes, that's a good question. The best I can say is there's work from University of Rome that was just published, I saw in PLOS, but I've known about for a while, where they have a theory that you shouldn't track the word flu at all, you should just look for symptoms of flu. And don't let people rely on self-diagnosis, and they show benefits to doing that. So we don't do that, but that is an approach that some people do take.
But it still doesn't eliminate the problem of news-induced hypochondria, right?
No, it does not. Right. And I don't think our approach is going to eliminate it, but it's going to make things much, much better. Okay. So we use a set of 3 classifiers. The first one is we just identify tweets as being about health or not. All this training data comes from Mechanical Turk. So that's our first stage. That gets rid of, actually, the first stage is a keyword search for health-related terms, and we've got a lot of them. So we get a lot of data that's not actually about health. It's a high recall phase. Then we have this high precision phase where we filter things out using a classifier so that it's really only about health. Then we have another classifier that doesn't just look for the word flu, but it actually is trained on tweets that are about flu and not about flu. And it tries just to find those that are actually about flu. So this gets rid of like swag flu, Ray Lewis flu, things like that, Bieber fever. And then the last step is awareness versus infection. So this is actually the most helpful and really the most interesting step. So what we're doing here is we want to distinguish between people who say, I am infected with influenza versus I am worried about being infected with influenza. So the example tweets I have here, on the left, so many Americans seem to have bad flu right now. I'm worried this trend will reach New Zealand in the winter. I might need to step up my inclusiveness. So this person doesn't have the flu, even though they're talking about the flu. And then the one on the right is my flu, cough, and fever is getting worse. I'm worried. This person, we would say, has the flu. Right? And so we built a system to distinguish between those things. We have a NACL paper on that last year, and it's basically a lot of shallow features, part of speech tags, things like that, to try and distinguish between these 2 types of tweets. Okay, we have a lot of training data, we trained that model. So that's how we accurately track ground truth, right? We identify this distinction between awareness of disease and infection of disease, as opposed to just who's talking about the disease, either with a classifier or with keywords. So the second thing, can we be effective at tracking flu, not just at the national level, but municipal level? Yes?
This is a good question. So just because I say I have the flu doesn't mean I have it.
Ah, yes. All the doctors ask this too. So, are you a doctor? Yes, you are. You are. So my response to that is simply this works. So, which indicates that however bad the problems with the data are. So one problem is people misdiagnose themselves. Right? Another one is that our systems have error. Another one is that the population is biased in all sorts of ways. Right? There are many problems with the data, but the system works, which doesn't say that those problems are real. It just says that the strength of the signal for influenza is such that it can overcome those issues. For other issues, that we look at, those biases in the data might actually cause problems, and so we do spend time thinking about how to account for them.
So when you say it's about signal, I think you're saying something a little bit more precise. That when you say it works up to a multiplicative constant. Like you're assuming that 1% of the people who have the flu will tweet about it or something like that, and you don't know if it's 1% or not. All you see is that you track the actual rate of the flu up to some constant, and if 10% of the people who say they have the flu don't actually have it, then you'll be off by a constant factor as long as it's always 10%.
Yes, that's right. And so that's essentially, right. So that's what I mean by it works well enough, is that the error there is much smaller, right? The 10% error is much smaller than the overall thing that we have, and so we still...
No, it's not even that. What if it's if 2/3 of the people who say that they have the flu don't have it?
Right, so
you're still going to just be off by a factor of 3, but it'll still track.
Right. So there's this other effect that's actually important, which is people's perception of what they have is influenced by people around them.
Right. And
so if I say I have the flu, it's probably because other people have the flu, so I think I have it. So even if you don't have the flu, you're somewhat reporting on other people's illness.
So how good can ground truth be anyway? Because when I get the flu, I don't tell anybody.
Right, you don't? You should. There's a service I should sign you up for. No, I'm serious. There is.
I mean, you're off by a multiplicative constant
right.
Anyway,
so,
because the ground truth has to be out.
Yeah, so this is a very important point, which is the CDC data that we're tracking is itself inaccurate, right? However, there is nothing more accurate than that to the rest of our knowledge, so everyone compares against it. But it absolutely has issues, and our error might be due not to the quality of our data. It might just be the fact that there's issues in the way they track flu as well. That's the reality here. All right. So we want to get signals for specific locations, right? So most people, there's one other paper that came out the same time ours did that looks at something besides national flu. But besides that, everyone looks at national rates. The problem is that we actually need local rates to make decisions. So there are lots of things you can do if you know the flu rate's going up. If you're a hospital, you need to call more doctors to the ER, clear more beds, stock up on Tamiflu. If you're pharmacies, you need to stock up on thermometers. Actually, you can track the flu by monitoring thermometer sales. You can, if you run a school district, you want to know what's going on in the school district, whether you should close. If you remember H1N1, a lot of schools closed because they want to prevent infection spread. There's advertising campaigns for a while. There was a billboard as I got off the highway here at Hopkins that was advertising something about the flu. It was in Spanish, so I don't really know, but it was about the flu. Anyway, if someone remembers this billboard and speaks Spanish, they can tell me what it said. The problem is that Twitter data is mostly not geocoded. It's about at 3% now. This slide is actually a little bit off. In the US, it's about 3% of tweets are being geocoded. But that's really not necessarily enough data for us to do local trends because it throws away most of what we have. So instead, we're just going to do something very simple that now lots of people are doing. So I'm very happy. Hopefully, they're using our code to do it. Well, we're going to look at the profile information. So this is 6 users and their profiles. So you can see that they say things like New York is their location, Florida, Arizona. So people have varying granularities of location that they're providing. We can get things like New York with lots of E's and O's. There's a pretty easy regex you can write that gets most of these. But I'll admit, does anyone know where that is?
Yeah, I grew up there.
You grew up there. Do you want to try saying it then?
Well, I don't have the classic accent.
Does anyone want to try saying it?
New Jersey.
There you go. I don't think our system knows about that, but I don't know why I just don't have it. So we built a system that basically can look at these strings and identify where in the world they are. That's called Carmen. We have 4,000 known locations, and the tests we have show that our geolocation goes from about 1% in the data we looked at to 22% of the data. There are others that have taken this approach to a greater extreme, and they're companies, so they have a lot more money to throw at this, and they're reporting things much higher in terms of the geolocation rate. But this is a very useful tool for us. We hope it's a useful tool for other people, so we post it in Java and Python if anyone wants to use it. All right, so that gets us a lot more location data. So the last question is this predictive, right? So can we take our classifiers, combine it with the location, and actually do something interesting or accurate? Here's historical data. So keywords is just the Health and Human Services has a couple keywords for Twitter that they recommend for flu. That's what this is. Flu classifier is the first two stages of our pipeline, but not the infection versus awareness. Google Flu Trends is Google's data. So in 2009, you see basically everything did the same. It was actually a really easy year. That was the H1N1 year. 2011 was hard because it was a mild year, and so there were much more subtle trends to detect. And you can see how different systems do. So you notice in 2011, there's a big gap between Twitter and Google. Here's how our system does. So 2009 does a little bit better, but it doesn't really matter. In 2011, you see a pretty substantial increase over both of the Twitter methods, cutting the error compared to Google roughly in half. Right? But that's historical data. How do we do it in real time? So we built this and submitted it to ACL 2013, which means we built it fall 2012. We then took that system and ran it on the flu season of 2012-2013, which turned out to be a really interesting flu season. We didn't really know that was going to happen. If we had known that, we would have published that paper. Anyway, so the black line is the CDC trend, the blue line is our system, and you can see it roughly tracks pretty well. We get the peak right here, we kind of get a smaller peak here, but okay, it's overall pretty good. This dotted line is just influenza tweets, not filtered by awareness. You can see there's two peaks that are really unexplained. The first is in early December, the second is in early January. Early January is when the big media campaign happened, so we see a huge increase in tweets around that. And early December is when the CDC announced that flu season was particularly bad, and so there was a smaller increase of coverage around that. Here are the correlation coefficients. I don't know exactly offhand what Google did, but I think we're very, very close to Google Flu Trends for this year. I don't know if there's, in fact, I'm pretty sure there are not going to be statistically significant differences. And a couple people did publish how they were doing on this flu season earlier on, and we were beating them pretty handily at that point. These are the best numbers I've seen. Michael, is that right? Yeah, okay. Yes?
Did you tell us how Google Flu Trends works? I know
I
it's on the previous
didn't.
slide.
I didn't, but I don't have time.
So
It's based on Google queries, and I can tell you afterwards how it works.
Yeah, okay.
Think about what you would do, and then step back 3 levels.
Yeah, okay.
No, Jason, 4 levels. And what else? 3, yeah.
So it looks like your error is worse sort of in the holiday season. Is that?
Holiday season. Yeah, I don't know. I'm not sure whether you should read too much into that.
I mean, are there things like people just, certain times of the year don't use Twitter very much at all?
Good question, Miles. Okay, that's the authoritative answer. I don't know.
So notice the CDC data also seems to have particular patterns around the holiday season because way fewer people bother to go to the hospital. So they do normalize for that, but you definitely, I don't know if it's biasing in some way.
Yeah. Okay, so then the next thing we want to do is show that we can do this for a city. So we picked New York City because, look, they have data. Most cities don't have data. However, the data they have that we actually need, they do not share publicly. So we saw this as an opportunity. So what we said was, we will send you our predictions, and then you will do the analysis so that we have no control over the answer, and then you will just tell us how well we did. So that's what we call a blind evaluation. And this is what they told us. That infection 0.88, keywords 0.72. They did not send us a curve, so I can't show you the curve. But the number 0.88 here, the things to take away from this is one, it's improving over the baseline again, and it's not much different. In fact, it's just barely statistically significant from the national trend. And so what that means is that we're doing almost as well in a much smaller geographic area as we would nationally. You guys want to know how we're doing this year? This is, I think, 2 weeks out of date now, but this is how we're doing this year on the same system. This is Twitter, black is CDC. It looks like we captured the peak at the right place. We have a 0.95 correlation this year so far. You can't really compare that, though, to the correlations before because it's over a different span of time, right? Although our correlations actually tend to be very, very consistent throughout the season. It's not like they're all in the low 90s or low to mid 90s whenever you measure. So this is the plot I promised I'd show Jason. This is the influenza classifier baseline. Here's our new system, and you see it basically ignores any increase from the blue media coverage. Okay, I gotta move on because there's one more thing. If you want this data, we're going to be releasing it online soon. Or you can just ask me because you're sitting in the room. It's probably easier than going to our website. Web forums. All right, so you can do a lot with web forums, and this is often overlooked by this community. We're doing a lot of different stuff here. We're looking at quality of care. You can actually, it's really unbelievable how you can measure state-level correlates with quality of care based on what people write in forums about the doctors. Prescription drug use, we're looking at aspects of that in forum data. What I want to talk about is about illicit drug use. Hopefully the pills and the dollar bills next to each other indicate illicitness, because these pills look the same as other pills. Okay. So let me first tell you about the data set, and I'll tell you about why we're using it. So we're using a data set called Drugs Forum. I'll just read you what they say. Drugs Forum is an information hub of high standards and a platform where people can freely discuss recreational drugs in a mature and intelligent manner. Drugs Forum offers a wealth of quality information and discussion of drug-related politics in addition to assistance for members struggling with addiction. So you see it covers a lot of different things. We're basically focused on discuss recreational drugs. That's what we want. That's what we care about. So we have 100,000 messages written by 20,000 users. The self-reported statistics are 87% male. That seems very high, but I don't have a good way of evaluating that. 50% American. It also has like Canada, UK, and then other languages that we don't look at. And then the age breakdown, it goes all the way up to the age 119. Is that it? Or something like that?
100-ish.
It's 100? Okay. So we have a long tail of, there's actually a lot of users of 120s, and we kind of throw them away. We don't use those in the age statistics we do. But I don't believe this number because you have to be 18 years old to sign up for the website, and I know that people under that age also like to use the internet and do drugs, so they're probably on this website, so they're probably lying about their age. So these age breakdowns are not necessarily very accurate. Okay, so why do we care about this? So let me tell you a little bit about the world of illicit drugs. So for a long time, this world was dominated by the big names, right? What are the big names of drugs? Don't be shy. Heroin. Ooh, there's a UK connection. I'll do that later. Speed. Johnson. Ecstasy. Miles is getting all of them. Come on, guys. What? Quaaludes. I don't even know what that is. Okay. It's a speech joke. Anything else? Meth, cocaine. What? Ketamine. Ketamine's a smaller one, but yes.
Nitrous oxide, glue, other
glue.
drug substances.
Elmer's is not as popular.
Those are discussed.
I don't know if Elmer's glue is discussed. Probably not in the same depth or seriousness as the other drugs. But it's unbelievable what people put into their bodies for different effects. I mean, what happens, for example, is there's like a veterinary medication that is like not really controlled because it's for dogs, and then all of a sudden you have a lot of people, and you order it online, and all of a sudden there'll be a big spike in people taking it because they realize it gets them high, and then the government has to come in and control dog medicine. Okay, so this is what happens. People just do crazy things. All right, so that's what it used to be like. It's changed a lot in the past couple of years. Now there are a lot of new drugs. There was a study out from the EU on showing that they average one new drug a week. In fact, this is the UK connection. There's a widespread belief without much evidence, but we're trying to show it, that the UK is a major source of drug innovation in the US. That basically all the really good ideas start off there and make their way over to us. So that's why you're here this year, I guess. The problem is that these new drugs, because there's so many of them, doctors are just not familiar with them. And this creates a whole lot of problems. So if you go into the ER because you've overdosed, and the doctor says, what have you taken? Forget the fact that you might not be able to speak. What have you taken? And if the doctor's never heard of the drug, they don't know what kind of drug it is, they don't know how much you should have taken, they don't know what to do. I mean, it's a big problem. Okay? If you go to see someone about your addictions, right, and they're trying to help you with your addiction, and they don't know what drugs you're taking because they've never heard of them, it's very hard to do their job. Policymakers, when they're trying to decide which drugs we should control, which drugs we should study, right, all these different sorts of things, if they've never heard of the drug or they don't know anything about it, they're at a loss. So this is a huge problem, and we're very interested in looking at this data because this is a data set that talks about these drugs fairly early on, before they show up in other traditional data sources, right? So for example, salvia. How many people have heard of salvia? Okay? So salvia is a fairly recent drug. It's not actually popular that enough people have heard of it. And we just have very basic questions, right? What demographic groups are using this drug? Is it adults? Is it teenagers? Is it men, women? How are people using salvia? Are they smoking it, injecting it, snorting it, eating it? There are other ways. What are the effects of taking salvia? What do you feel like? What are the negative health implications? These are all questions that we don't have answers to because it's a relatively new drug. Right? Salvia is a case of a drug that got very popular, and so now we know information about it. Does anyone know why salvia is very popular?
It was legal.
It's now, it depends on the states. Obviously, it depends on the state, it depends on what country as well. But it certainly started off as legal and is now moving to the illegal camp. But does anyone know why it's popular? Many, many things are legal that you have, but why did salvia become so popular? No one knows. Okay, this is a little bit trivia. Miley Cyrus. So there is a YouTube video of her smoking a bong with salvia. It got posted online. This is just one, there are many copies online. And believe it or not, kids like Miley Cyrus, and so they started smoking salvia too. And there was actually, I think it's salvia, there's this trend of teenagers basically getting in front of their computers, taking salvia, and then recording themselves doing crazy things the next half hour, and then they post it to YouTube. I don't know if these videos are still up there, but for a while you can find tons of these videos of teenagers doing crazy stuff when they're high. Anyway, but just to show you, actually, YouTube is a very serious source of this stuff. What's the #1 recommended other video? Justin Bieber smoking weed. He was in the news again. Bieber fever's back. Okay. So the way we're going to study this corpus is we're going to use topic models. The reason we want to use topic models is we have, at the heart of what we're doing is an exploratory task. Right? We have a lot of corpus of data. People actually do already use this corpus to study drugs, but what they do is they basically just read lots and lots of foreign messages, thousands of these things. They'll code them, and then they'll write a paper. And we want to enable much better analysis of the data. So we want to enable people to find things that are of direct interest to answering their questions. Topic models are a promising way of doing this. The trouble, though, is topic models can only do this topical division of the data. And so what we have is factorial LDA, which, Michael, have you talked about this here? No. Okay, no. All right, Friday? Next Friday? 2 Fridays? You're not talking about this? All right, fine. So I'll say a little bit more. So what FLDA does is it models corpus not as just topics, but it's a joint model of multiple aspects. So let's say you're interested in topics and sentiment, both of which can affect what appears in the document. So we actually can model those jointly by saying that words are not going to be chosen just based on the topic that they come from, but they're also going to be chosen based on the fact that they're topic and they're this sentiment, right? And we can do this for an arbitrary number of factors. So for example, on ACL abstracts, we did the topic of the abstract, the approach, and the method, right? So you got things like theory, it was like theoretical methods of speech, or empirical evaluations of entity, like those sorts of things, as topics, right? So that's the idea of FLDA. I'm not going to go into the details of how it works. I'll just talk about it very high level, okay? So we used a 3-factored FLDA model for this data set. The first factor is going to come from the drug. So we have 24 different drugs we're looking at. Those are some of them. The delivery, how you get the drug into your system, whether you inject it, you take it orally, you smoke it, you snort it. There are like 20 or 10 different ways to get drugs in, so I'll give you guys extra points if you can name them all. Actually, I don't want to know if you can name them all. And then the aspect, which is things like the chemistry of the drug, the culture around it, the effects of taking it, the health impact, and how people typically use it. So, for example, if you look at the topic that is discovered, or the joint topic that's discovered for alcohol, oral, culture, you see a lot of words like parties, frat parties, college, that sort of thing. Where if you look at like meth, injection, you inject meth? I don't want to know. Meth, something else, and culture, you see a lot of words that are not, I don't want to say that, but there's a very different culture around meth, okay? And heroin and things like that. So you really can see very interesting things fall out of the data. So this is some example of the word distributions we learned. So for cocaine stored in health, we get things like nose, pain, damaged blood. Cocaine stored in usage, we have things like coke, lines, cut, small. So what's interesting is what FLDA does is it says, I want to learn these two distributions. These distributions should be, for all intents and purposes, the same, except for the fact that one is about health and one is about usage. Right? And so the only difference in these two distributions should be words that belong to health or usage, but in the respect that they're both about cocaine and snorting, they should be the same. Right? And you really see this as you look at the larger lists. So the question is, how do we actually make that happen in this data? Right? How do we ensure that FLDA learns that sort of thing? So the way we do it is we first learn general word lists. These are not necessarily distributions. Yeah?
What does small mean in the previous slide?
I don't know. Cocaine snorting usage small. Does anyone like to get? I don't know a lot about it.
They do cocaine, but only a little bit.
A little bit? Michael, do you happen to know?
I don't know. It's hard to say with the bag of words approach, but maybe small, like make a small line or something.
Yeah, I have to look at data. Sometimes, so we actually have ways of expanding these to phrases and stuff like that I'm not showing here. And those usually are more illustrative. And when we show them to users, like in a practical setting, that's what we'll end up doing. So how do we get this to happen, where these tuples are very similar in behavior, right? So I just want to give you an intuition for how this happens. So what the model actually done is it learns separate word lists for every one of the factors. So cannabis, oral, and chemistry, by themselves, have word lists that the model learns for them. So this is words that are generally associated with chemistry, regardless of the drug. Words generally associated with taking something orally, regardless of the drug or how you're using it. And you can see that it kind of captures that. And these are words generally associated with cannabis, regardless of what you're going to do with it.
And how do you generate these lists?
These are inferred from the data. Right? So they're everything I'm going to show you, except if I say otherwise, is unsupervised from the data. So each one of these is basically a weight vector over the vocabulary. So when it comes time to say, we want a distribution, model, give us a distribution for cannabis, oral, chemistry, what we do is we take these, we combine them to get a word list that reflects all three. Right? So this word list is, in some sense, a combination of the words associated with each one. Right? So this is what the model expects cannabis, oral, chemistry documents to talk about. Of course, what the model thinks about the world and the world are very different things. And so we just use it as a prior. And we say, well, given that that's what you think the word list should be, why don't you actually use that as the parameters for a Dirichlet and sample the actual distribution that corresponds to cannabis, oral, and chemistry. And so what this allows the model to do is fit the data, because it gets to fit this distribution in the data, but be heavily influenced by general trends across cannabis, oral, and chemistry. Right? And this way, you can have cannabis, oral chemistry, cannabis, oral usage, and they're encouraged to be very, very similar, except for that one list that went in that differentiates each one. So cannabis, oral, and chemistry, what are all those messages going to be talking about? Does anyone want to guess? You have the word list. What?
THC and brownies?
THC brownies, yes, pop brownies. Okay. And that's what these messages are. So we want to answer these sorts of questions. How are people using salvia? What are the effects of salvia? Things like this. So the way we're going to do it using this model is extractive summarization. What we do is we run our model on the corpus, and then we say, if someone wants to know about how people take cannabis orally, we're going to find the sentences that are best explained by that tool. Right? And then we normalize so that we don't, we get reasonable sentences and things like that. So here's what our model found. How are people using salvia? So smoking versus oral usage of salvia. And we get things like the best way is to use a torchlight or bong or pipe. Bong recommended, that's not my recommendation, it's the person's. And hold in each hit 20 to 40 seconds. That seems like a really good explanation of how to use salvia smoking. Orally, I'm not going to read this because it's kind of dry, but it's very detailed instructions of exactly how to take salvia orally. We also can ask about the effects of taking salvia. So we see things like the oral effects when chewed. The first effects are felt after about 15 minutes, and then explains more. That seems great. Here, salvia smoking effects. He then took one large hit and held it in, and then you have this very description, orangish, brownish light. Right? People are explaining what happens to them when they take this drug. So these seem like really good matches. So 2 points. So one is I just want to point to a kind of an interesting aspect of the data. So he then took one large hit. So who is he? Like, who is this person talking about? So one of the rules of drug forums is this is for discussing recreational drugs, but no one here takes drugs. Okay? And so as a rule, you cannot say, I took this drug, because that's against the policy of the forum. So instead, everyone on the forum has friends who take drugs. And so people write things like SWIM, which stands for someone who isn't me, blah, blah, blah. And then people will reply SWE, which is someone who isn't you, blah, blah, blah. People will get much more creative. So there was one was, my pet rabbit Harold, parentheses, 6'2", male, 250 pounds, went to the club with his girlfriend for the weekend and did the following drugs. Right? So that's really kind of just an interesting side of the data, and you actually see it show up in the topics. The second thing is, how do we know this actually works, right? So I've just shown you some examples, but you can't publish a paper on examples alone. Well, sometimes a top model paper, but you shouldn't be able to publish on examples alone. And so we did two things. One, we showed this to our colleagues in behavioral psychiatry, and they said, wow, these look great, good job. We also can't publish a paper based on that. So we did a study. What we did was we found technical reports that were written about drugs, and we excerpted the paragraphs that describe, the smoking effects and the smoking usage and things like that. And we showed that paragraph along with a bunch of sentences that our system and baseline systems extracted, and we asked which one is helpful for writing this report, and our system was picked more than any other system. And if you want to know exactly how much was picked, you can see the paper. This is a NACL paper. And we're currently submitting this work to the drug addiction community with a bunch more results. All right, so that's what I wanted to say about this sort of data. There's a lot of people to thank, so I listed them all here. They've all worked on some of this. If you're interested in seeing more about this work, you can just come and find me, or Michael, or a bunch of other people. But we also have a website that lists some of the projects we've been working on. And of course, if there's something you guys want, code, data, all that, just ask. Thanks a lot. Yeah, you guys made it first.
So you made a point at the beginning of the drug forum about how rapidly new drugs are coming on.
Yes.
Can you use do you have any way to track what the new drugs are and
right? So
informative thing for.
Right. So this project was the exploratory project that just showed us what the data was like. We have a list of years worth of research now that we want to do, and that's one of the main issues. So we know that this data supports that. So bath salts, anyone know what bath salts are? And if you think you put them in your bath, you're not thinking the right thing.
You have to think zombie.
You have to think zombie. That is the right thing, although that is a misnomer. But zombie is the right thing to think about if you know what to talk about. Anyway, so they were very popular recently because they cause cannibalism. Actually not true, but that's what people thought. A drug that causes cannibalism is going to get a lot of attention, so it did. That was last year. We have messages from 2006 or 2007, I think, talking about bath salts. So we know that this stuff shows up way early, like years before it hits the mainstream. And part of that is because there's so many new drugs coming out, most of them don't make it. Only a couple of them actually make it to the big time. If bath salts is even a big time. And bath salts is still a very niche sort of drug that most people don't use. But certain communities it seems to really trend because of the UK thing again. You think I'm making that up? Seriously, the UK thing. They give us drugs. Anyway, so we have a lot of questions that we want to answer about this data. It's a problem. Other questions, things you guys want to know? Yeah?
Yeah, I'm just curious, if you tried a consensus model, Google and tweets, for example, for the flu, would that improve things?
Google plus tweets. Oh, wow, we never thought about that. Will it improve things? So, well, yes, because the rule of ensemble learning is when you add more things, it always gets better. So there are technical difficulties, though, in adding these things together. Part of the big difference between what Google does and what we do, and this is huge. It's kind of amazing that we do as well as we do, given this difference. So we don't train on CDC data. So nothing I said had anything to do with CDC data except evaluation. So in that sense, we have an unsupervised method. Okay? We don't call it unsupervised because we're training classifiers and labeled data, but it's unsupervised in that what we're trying to learn and track, we don't see. Google's is a supervised system. They actually look at lots of historical data and they fit models to it. So Google can do that because of the nature of their data, and also they have years worth of data. Twitter has not been around long enough for us to fit reasonable models. When we've talked to people about doing this, their response was, you don't have enough years of training data yet in order to do this. My response was, I have ways around that, but we have not pursued it. So it is something we've thought of. I think in practice, the way this stuff gets used, I'll tell you what the state of Maryland does, for example. State of Maryland has a weekly flu report they put out, and they don't say the flu rate of Maryland is X. What they do is they say, they have a paragraph describing the data sources they have and what they seem to be, and they have a bunch of data sources, and they show all of them, and they try and paint a more nuanced, complete picture of what's going on, right? So in practice, even though we're showing these correlation numbers, that's not what people care about. People care about making decisions, and so the question is, how can we support those decision-making processes? So for example, we've evaluated, in weeks where there's a substantial change in the rate of the flu, how accurately does our system guess the direction of that change? And we're 100% accurate on that. And I think that's a more useful output. I can talk a lot more about this, but I'll answer your question. Yeah?
So 3 questions, 2 very quick ones.
3.
And a hard one. So do you think that using the 1%, this is for the flu stuff.
Okay.
Do you think using the 1% hurts you?
We don't use the 1%.
Oh, good.
Okay, so no.
That easy question. That second one is, why don't you do geolocation prediction instead of just using the tweets, the 1% or expanded set that have?
Because it's more work, and we haven't done it.
Okay.
So there are a whole bunch of things we can do on top of what we're doing. This set is also, the Carmen is actually based on an expanded set that we got from a paper that I think David, me, Ben, a couple people were on, and Shane last year at NACL about learning. One of the things it did, it used the social network of Twitter to learn a bunch of associations between things. And one of the things it gave us was lists of locations that are synonymous. So we use like that list as well to give us a little bit more expansion. There are other things you can do, like if someone says, certain words associated with Baltimore a lot, you identify them as being in Baltimore. We don't do that primarily because it means we have to look at more than one tweet at a time, and that makes things harder. So that's true. I mean, sometimes you have enough signal from a single tweet. But we are thinking about things like that, but it's harder, so we haven't done it.
Yeah, of course, it's not work, yeah. But the real question is about bias in the data.
Bias?
Bias. Right.
Okay.
So the thing about the CDC sort of surveys and so on is you have an idea of your people, you actually see them, right?
Yes.
You never really know whether they're people or maybe bots and so on and so forth.
Yes.
So it's always going to be this uncertainty about the results that you get from Twitter.
Right, so that is true. So it depends on what you're trying to do. So when you're trying to do disease surveillance, there is no way we're going to replace what the CDC has. Right? And basically the conversations with the CDC are not how do we replace what you have, but how do we add one more data point to give you a better picture. They're not going to take apart their network. So for them, there's a certain level of trust we're not willing to put into it. For other applications that we're looking at, there is no data. Like basically, people have, there's areas that we're looking at where there's only theoretical studies published because no one has ever had a data set to answer these questions. So even though there's bias, it is data with bias as opposed to no data. And so the questions we deal with is like, okay, can we measure bias? Can we account for bias? Those sorts of things. But it's just such an improvement over the status quo that we try and improve it. It also helps that surveys, which are the gold standard in public health, have all these same problems. So surveys undersample young people, they undersample cell phones, people are known to give censored answers to surveys depending on sensitive topics, there's priming problems, there's tons of problems with surveys. If you actually look at polling in detail, it's amazing that any of it works. And yet, because it's the data that people have, we have a huge community around accounting for these problems and trying to address them. So I think the same thing is going to be true of these data sources as well.
The problem with bias is it's not particular to your work. This is the general problem. We all work in social media. And it'd be nice if someone actually addressed this or tried to address it.
Right, so my suspicion is that for other sorts of problems we're looking at, where bias will have a bigger impact, then we will need to do some accounting for bias. And so, reweighting our distributions and things like that. I think we can do that. Any other questions? All right, thanks for coming. You know where my office is.